Bom dia, acá estamos Aníbal y Ciro Rodríguez moderando la sesión.
Bom dia, Anibal. Felipe e Maia aqui, diretamente da sala híbrida do laboratório do Hospital Pedro Ernesto, da Universidade do Estado do Rio de Janeiro. É um prazer poder estar aqui hoje com um time de muitos experts para poder apresentar para vocês um caso de fechamento percutâneo de apêndice atrial esquerdo. Eu estou cercado aqui hoje por um time muito capaz, muito competente, com a presença de dois convidados ilustres, professor Ole de Backer, do Riggs Hospital, e professor Fábio da Sândoli Brito, conhecido de todos nós, uma das maiores referências na cardiopatia estrutural que nós temos aqui na América Latina. E eu, nesse momento, antes de apresentar o restante do nosso time, peço desculpa à parte da audiência, mas nós vamos seguir falando agora em inglês, já que nós temos um convidado internacional dentro de campo. So we're surrounded here by our full team in the cath lab here from the State University of Rio de Janeiro. We're going to have in the eco team, Mônica Alcântara and Marcelo Iso, and our nursery team is going to be captained by nurse Elisângela. So we're going to move on with the case. Fábio, where is John? John is our fellow who's going to be presenting the case for you guys. We have a very interesting case here of a male patient. Can you have the factoids, please? Okay, João, our second-year fellow is going to go on. Please, João.
Our case is a male patient, 79 years old, previous liver cirrhosis.
Não tá sem o som do João.
Peripheral artery disease.
Louder, please.
Yeah, just.
In February, showed esophageal varices when DOAC was interrupted, and he was treated by elastic bandage. Echocardiogram evidenced just a minor atrial dilatation and minor aortic stenosis with LV hypertrophy. He scored 3 points in CHA2DS2-VASc and 5 points in Hasblad. And the CT scan showed a chicken wing anatomy, a perimeter-derived diameter of 26 millimeters without any thrombus. Matching the 3D CT reconstruction with artificial intelligence,
Pois é, eu estou sem o retorno do áudio dele.
We can simulate the septal puncture type and
Consegue
position.
checar lá se eles estão ouvindo?
And now I'd like to invite Dr. Debaca
Eles estão ouvindo,
to
doutor.
explain a little bit
Aqui
about
que não dá para
our
ouvir
pre-procedure.
Okay.
Eu aviso quando acabar o caso, a apresentação do caso.
So I think we can have Ole here who has described the technique for the transeptal puncture. Ole?
Yeah, this is in an REO 45-degree angulation, so that's to see whether the posterior or anterior puncture is the best. You saw that the posterior transeptal puncture would give the best coaxial alignment with the central axis of the left atrial appendage. This is now in an LAO view, so now we see the superior and the inferior aspect of the fossa, and you see also here an inferior transeptal puncture would give us the best coaxial alignment to cannulate really into the LA. So we're going to aim for an infero-posterior transeptal puncture, which is typically the best in 80-85% of all cases.
Yes, please.
And then here, this is a 31 millimeter Watchman flex in a distal position, as you can see, simulated or with computational modeling. This is a 31 millimeter flex in a proximal position, still acceptable, although borderline compression, then it's according, but this is very proximal. We never ever want to implant this more proximal than this. I think in real life, we're going to implant probably a couple of millimeters deeper in, and this is on the model giving 10-12% compression. So I hope we can go for 15% or 16% compression if we aim for and we can obtain the position we have in mind. So also here on the chart, you see for the 31, so if we go for the position we want, we should have around 16 or 17 30% compression of the device, which is good. It's within the limit between 10 and 30% compression. Yeah.
Perfect. So we're all set here. We already have our venous puncture. We have our Swartz pass by. So we're going to go on with the transeptal puncture.
Yeah, so this is the classical SL0 and BRK needle. This is not the VersaCross system yet, but this is the classical setup. And be careful, the stylet is still in, but we pulled it a little bit back. Yeah. All right, good. Maybe you can also see fluoro, if you can stream fluoro as well, so then people can follow where the transeptal sheet and the transeptal. So if we can show now, maybe most
bota a imagem da Anjo,
if you
por
can
favor.
stream both fluoro and echo. So Felipe, tell us what you're doing with your hands. So you're holding this at around the flush port and the arrow to 3 o'clock, 5 o'clock?
I'm around 3 o'clock right now. We're up in the superior vena cava.
We should see echo too. Yeah.
So we're going to start to go down around 3 o'clock, I would say so. So I have my right hand on my needle. My left hand is going to help to put the Swartz down. And I have one hand in between those two. I mean, one finger.
So you can already go to 4, 5 o'clock, I would say, because we aim for a little bit posterior puncture. So just go
Felipe,
to
você pode
4
pedir, por
o'clock,
favor,
for
para pôr o
example.
eco na tela?
All right, good.
Now we can see it
that's
perfectly.
all right.
We see the echo also.
Okay.
We
Okay,
see the
that's
beta
nice.
valve.
Okay, waiting for the first drop from the superior vena cava to the right atrium.
Yeah, that's now.
Yeah, that's now.
That's just in the right atrium. And then now we're just in the top of the fossa, yeah?
Yes.
So then it's a good, what I typically do if we're in the top of the fossa, I ask for the short axis view, because then we know before we pull a little bit more inferior, if we also give it a little clock posterior or not. So let's ask for the short axis here for the echo. And you see here, short axis, we're not very posterior yet. Yes, we're just more like midish. So then while we pull down, or Felipe will pull down, slowly, he can give it a minuscule, a little bit of clock, extra clock. I'll talk about that here. So let's wait here. That's your very nice posterior now, Felipe. So that's great. So that's good. And then we can ask for the bicaval view. So we know we're good there. And this also looks good to me. Wait a second. Yeah, we're not even ridiculously inferior. But I think maybe
we're good
enough. Yeah.
Seems fair enough for me.
How does it look on fluoro? Yeah, it looks also there reasonable. So I think I would accept this, or if anything, I would pull it maybe 1 millimeter lower, 1-2 millimeter lower, but not more than that. And then I would go for the transeptal puncture.
Okay, I just did.
Yeah,
Felipe.
right, good. This is great. And
Martin.
now I would go for the transeptal. Okay. Yeah, you're nicely across now. I'll try to use your mic also a little bit, Felipe, then. So now let's centralize a little bit more. Can we see a little bit more of the right side? Can you bring the table a little bit more to us so we see a little bit more of the lateral side of the heart? Table to us. Yeah, perfect. Yeah, that's good. Okay, Felipe, so now you can push your sheet over. This is great. Yeah.
Yes.
Okay. So now it's very important we gave full heparin, or maybe you already did.
Ok, vou fazer o resto da heparina.
Just a technical question here. The tenting here in septum was consistently very good. Do you always bend the catheter or the Brockenbrew needle, or just in specific cases to get this kind of tenting?
Well, I usually bend it a little bit, depending on the device that we're using. This device with the BK1, I usually tend to not to bend it. But we have used other devices in the past where you don't have that much of a large curvature, so it can be done definitely.
Yeah, this was, I don't know, can you hear me now or not?
Yeah, perfectly. We
Can
can
you hear
hear
me?
you clearly.
Yes.
Okay. So this was a BRK needle, not a BRK1 needle. So this was a BRK needle. I actually shaped it extra. So I gave it almost a 90-degree angle and a rather large curve. So that's what we did. And then you see, typically it's good in these patients because it's patients with atrial fibrillation, long-standing atrial fibrillation, dilated atria. So yeah.
Dr. Rowley,
Good. So now it's the moment to bring the multipurpose. The wire is already nicely in the left upper pulmonary vein. So now we bring up the multipurpose catheter there to exchange then for the Amplat super stiff.
Dr. Rowley, can you hear me?
Yeah.
How often do you use the
Yeah,
Bailey's?
you can hear you. Yeah.
How often do you use the Bailey's
Well, to be
system?
honest, yeah, since 9 months, I transitioned completely to the VersaCross. So I don't use in my own practice, I don't use the transeptal needle anymore. I go now fully to the Bailey's VersaCross. But of course, at a certain cost, it's a great system, to be honest. Yeah.
Okay, take.
Okay. Okay, so now the Amplat stiff wire is nicely positioned in the left upper pulmonary vein. It's an Amplat super stiff with a 1 centimeter floppy part where Fábio made a small curve on, and now it's time to take out the transeptal system. I can help you with that if you want.
Yeah, sure.
Felipe, and then you can compress there as well. Yeah, you do the first part here, and then I'll take over from here. Yeah.
Go ahead.
Yeah, this is live fluoro, and then you compress and take the wire. Yeah, okay, and then Fábio, you put on the transeptal sheet here. So this is the double curved true seal sheet. Yeah, all right, wait, be careful. Yeah, all right.
Anibal, Marden, Enio, I understand we have a very experienced panel. We're having a bit of a discussion, the beginning of the procedure here. I would like to hear from the panel, what is your routine when you take the transeptal puncture? Do you guys usually go the full dose heparin before the TSP, or you guys do a half dose before the transeptal and then you complete the dose? What is your routine?
I thank you for the question. I will start. I still do half dose before the puncture and half dose after the puncture, but I understand that when you guide the transeptal puncture this way, you can do all the heparin before the transeptal puncture without any safety concern. I don't know, Enio, if you agree or if you do it differently.
I do the same way. I think that
Okay.
the transeptal puncture under echo is totally safe. And then I do half just as you do.
And actually, I do the full dose before the transeptal punction because we guide by echo and then it's very safety. And now we transition to IC2 and then you need to do the full dose
JY.
before the punction.
Come.
I
Okay.
think that there are different
So
strategies
we're-
according to experience, but there's no concern about doing the full dose before the transeptal puncture at all.
No. I mean, this is a controlled procedure and transeptal puncture under TE guidance. So, I mean, there's no risk on giving a full dose heparin, I would say, beforehand. So now we put the pigtail on. Yes, we go in with the pigtail. You don't have to put the wire up yet because we have to see it back at the end of the pigtail.
Yeah.
All right, we're almost there. So now Felipe is going to place the pigtail into the left atrium and try to cannulate the left atrial appendage.
Yeah. So we need echo image as well here, guys, please.
So there we see it. Yeah, okay.
Okay.
Felipe,
Can you
what
see
the,
our
proje-
echo?
what the projection to choice for the Phelps?
Yeah.
Oh, this is a very good question, Marden. Yeah, we're gonna work in Caldo 35 and in right 35 and Caldo 5.
Let's do that. So let's go REO 33, caudal 5. Let's do it now. Yes. Be careful for the feet of the echocardiographer. Yeah. Because they don't appreciate that typically.
And we like them, so we like to keep them close.
We don't like to injure them. So this is the REO 33 caudal 5. Yes, okay, that's great. And now Indeed, the pigtail is out. So what we will have to do is go counterclock, quite a lot counterclock with our delivery system. Yeah, I'm pretty sure you're in the appendage now. I already see that. Okay, and then now, can we zoom a little bit in also? Can we zoom in?
Yeah.
On the fluoro? Yeah.
Yeah, I like to do this movement always on a counterclockwise to have the sheath mostly inside the
So look,
appendage.
on echo, you can see you're just across the circumflex artery, yes?
Yes.
So we can prepare for a little bit of contrast here. You do that as you want, either with the pump or you want to do it with the pump, you can do it. Yeah, like with the connection you have. Yeah, all right. So I do not like to give contrast through the pigtail. It's better to give the contrast through the sheet, I would say, because then you can opacificate the appendage better. Yes, it's denser, it's more correct. So if you do it through a pigtail, it's sometimes not the clearest picture you get. And you see that on the echo, there's quite some spontaneous contrast as well in that left atrial appendage. You see really, as we call it, stroke. Maybe
let's do that way because they
let's do it this way. I think it's going to be safer like this because there is some air otherwise.
Tá com a linha de pressão arterial? Okay.
All right, let's disconnect this and let's bleed it out a little bit so we're sure there's no bubbles. It's really important you make sure there's no bubbles because that's something you do not want to have in the left atrium.
Felipe,
I'm just gonna fill the sheet now first.
The
Yes.
TE operator from here because he's giving us amazing pictures. We are seeing very clearly the TE, so congratulations to them.
Okay, Felipe, are you ready for a cine?
Yeah.
Maybe we can zoom one zoom extra.
Just a second.
Yeah, all right, this is
okay.
good. All right, cine and okay, that's nice. I think. Look, what can we tell about this? So first of all, the sheet is nice and good enough in. It's a large appendage, which confirms the pre-procedural CT. We're good enough in. We don't have to go deeper than this. In the distality, there's two small different lobes. Yes, we are in the superior lobe, but that's typically good because you see the coaxiality of our catheter with the central axis of the appendage is excellent. Yes, and that's thanks to a good transeptal puncture. So I think we're in a good position here. Then you can also, maybe Fábio, you can comment or Felipe on the markers there for the delivery sheet. So do you look at this? You do not look at this? What's your habit to do? Do you do sizing on angio or not really? Felipe?
Nowadays, not anymore. I don't like to do the sizing and the angio. Usually, we are used to use the markers for the first generation, the 2.5. Nowadays, I usually don't use them too much. I really trust the echo from the image inside we have, and all of a sudden we still have all the pre-planning from the CT scan. Do you usually do, Oli? Do you use it?
I use it just as a visual check that it accords, it's in line with the measurements on CT and or TEE. Because maybe we can ask the echocardiographer to show the measurements she made, yes, so the audience can see.
Yes.
Before we started the case, she did some quick measurements here. So maybe she doesn't have a mic, so maybe Felipe, you can comment what you see here. This is in the 0
Yeah,
degree.
this is 0 degree. She measured 2.2. We can go now on 45, and the highest diameter that we have is 2.0, 20 millimeter. Okay, she's gonna keep on rolling. I'm going to go to the 90 degree angulation, okay, 18 degrees, and then 135, I think it's always the hardest one for the eco guys, okay, and it's around 2.5, so I would say it's a little bit under what we measure through the CT, what is expected. We have a good atrial pressure here, so we had to be careful to take this patient before to the hospital, so to get a good hydration, because it can be kind of a bias when the patient is got a low volume inside the atrium.
Dr. Oli, do you change your strategy during the procedure if you see different measure in echo or ICE, TE or ICE? What do you do in your practice?
Yeah, I mean, it depends then even from which device you're working with. Now we're working with the Watchman Flex. We know a Watchman Flex is a very conformable device, I would say. So it's more forgiving for oversizing. So if you are in a gray zone, a borderline zone, that can be based on your CT measurements or your TE measurements. It can be that you doubt between two sizes. But But then if on fluoroscopy you see that you have really good depth, I would say then you're maybe better to go for the larger device, because it's a very conformable device. It can go from this marshmallow to a hot dog compression, so it's pretty conformable, I would say. But okay, here I think we agreed on, and we would stick to the 31 millimeter device.
Yes.
27 is for sure too small. 31 or 35, that's the question. We have enough depth, but we think we will have some shoulder with the 35, and we do not particularly like a lot of shoulder. So I think we're going to go for 31 here. We believe that we will have just enough compression, something like 15% like this, and have enough proximal coverage. We will not cover the complete all the way on the echo all the way to the anatomical ostium, but that's also not always what we want to obtain. We don't want to close the complete anatomical all to the way to the commodon ridge. That's not really our goal all the time. Yes, and here there's no trabecularization there, so it's a smooth part. So I think we can accept a little bit a slightly deeper implant. Yeah.
The thing about this new generation device is that it's very forgiving when we're sizing the device. You know, it has a wider range than the first generation. But you would say that maybe using the FIPS, we were using the FIPS earlier this morning, the 3D with AI, and we can go definitely 31 or 35, but after we saw the images of the pre-planning with the 35, with too much of a big shoulder outside the ostium, so that's was maybe critical for us to decide for a 31.
Okay. Should we show the flushing? Maybe the camera can show.
Yes.
Here, can turn around for 2 minutes. And me and Fábio were, in the meantime, flushing the device. So what do we look at? The nice thing with the Watchman Flex is, as for people who are not familiar with the device sits already in a long kind of sheet, delivery sheet, and that's really nice. So it's easier to avoid bubbles or air. It's important to check that the device is really to the ring. I don't know if you can film that, but the device should sit all the way just to the radiopaque ring marker. Yeah. So we check that. And I can even pull a little bit back on it, on the device. Wait a second. Yeah, now it's, yeah, I'm pulling back. Now I'm trying.
Not too much. Yeah, there.
Let's see.
Yes, yes.
Let me check a little bit more, maybe. We really want to. So what you can do if you have a very shallow, appendage, not deep appendage. So now we're flushing. Then you can even let it stick out a couple of millimeters. Wait, I'm going to take some extra flush. So that means you can push the device 2-3 millimeters beyond the ring. Okay, I'm going to close this here now. And then now this is closed, the hub at the end. And now I really have to flush the whole catheter. That's a big one. Okay, that's maybe better. So it's really important to flush enough, I would say. You can't flush enough these devices. Let's get this full syringe still of 50 cc, and then let's flush this completely, and then we take still a new one. Yeah, I don't think there should be air in anymore, so now I'll take a full one to make the running-to-running connection when we go into the sheet, yes? Okay, good. So we're almost there. The device is almost ready. Okay, I think we're there. We're good. All right, good. You take the device, Fábio. Be careful for the wire here. Be careful for the wires. Yep. All right, good. So let's see if you're still. I think let's go echo live. Then we can see if So Felipe, you can see I would push the device. The delivery sheet. A couple of millimeters deeper in, like 3-4 millimeters deeper in before pulling back the. Yeah, that's enough. Yeah.
Yeah.
Right.
Okay. Good enough.
Okay. Now,
while all is pulling back the pigtail, I like to keep a little bit of a pressure in here, so to make sure that we're not gonna lose position.
Okay, and now we're gonna make the running-to-running connection. That means we have to see blood coming out, and now you flush a little bit, maybe. Fábio, yeah. All right, that's good. And then now Felipe, he tightens a little bit, not completely, but he tightens a little bit around just to stop the bleeding indeed. So, okay, now Felipe is going up in the sheet with the device.
Okay, guys, so we're driving the device through the delivery catheter now.
And tell us what you look at, Felipe, so on that marker, and what do you do with your hands? Maybe it's
Okay.
Can you comment on that?
Yeah, I keep a little bit of pressure anti-clockwise.
That's good.
So we're gonna go with the device until our last band marker, which you can see the distal one.
Yeah, we can always pull back. Yeah.
Okay, so when I get to here, it's a time we're gonna make the connection in between the sheath and the knob. So at this point here, if somebody can you show our hands here?
You can really film on Felipe's hands.
Yes.
So Felipe, you are holding the device.
Yeah, so right now I have my right hand here, just holding the knob, and I'm gonna bring back the sheath. So we have the connection here. So you're gonna hear the pop. So we're ready for the attack zone, I would say so.
So now maybe this white part is connected, that's the device, is connected with this hemostatic valve of delivery sheath. So this is connected. So now Felipe will go bring his hands here to this distal part, yes?
Yeah.
And you can open up the hemostatic valve there. So we have the playroom to play with the device. So also on echo, you can now show more echo with the camera again. So people can follow there.
Yes.
So you can look to the echo. Echo. Yes,
So
correct.
what we're doing now, I'm gonna start to bring the delivery sheet. So we're gonna make the ball.
Yeah. So how do you do that? A little bit push and a little bit pull on the catheter?
Yes, a
Both?
little bit of both.
Yeah, I would do the same. I would do also a combination of both. Because we are working with a pretty large device, so we need our depth here. Otherwise, the device will come to sit too proximal.
I would say we're good here. 2 times the delivery sheath. Don't you think so?
Yeah. Yeah.
So this is the time, this is the position in that it's very comfortable for us to work. This is the biggest of a difference from the first generation Watchman. So now I can pull it forward, I can bring it back. You know, the anchors are not exposed at all at this time. So it's pretty much safer, the procedure, and it relates with the low number of events that we have during the implantations with this new device. So we're gonna connect here the syringe with contrast. So we can make a few shots just to be sure about our position. From the echo, I'm pretty much sure you guys all can see. We can see the ball is around half, or maybe 1 centimeter distal to the circ, which will be a very good attack position for us. Don't you think, Oli?
Yeah, I agree. If the ball is roughly 1 centimeter distal of the circ, it's typically good. So yeah, okay, let's make a cine now. Yeah, a short cine, a little bit of contrast. Yeah, so we are a little bit in that small lobe, eh? So you see that?
Yep.
So we have to get out of there, but I think it will almost automatically come out of there.
Yeah, that's what I
to be
thought.
honest.
Yeah.
So, yeah. So as soon as you will do, I would continue combining the push and pull. So but not too much push on the device. A little bit of push on the device, and mostly then maybe pull back on the delivery, and then I think it maybe comes to sit really just nice in a good position. Yeah.
Yeah, so can you see the echo images as well?
Let's show echo as well.
Yes.
Echo and fluoro.
Can I have both the images? We just have the fluoro for them.
Felipe,
Echo,
Ole,
please.
and Fábio, do you agree what we can see from here, that if you want, you have plenty of space proximal to accommodate the device if you want to get to
Yeah.
a shallower position? Do you agree?
Yeah, we will, but that's the thing, the device will jump a little bit, we will allow it to come a little bit more proximal. We don't want to implant it in this distal lobe, but it's fine, it holds us now in the right direction. We will just use that small lobe in the distal end to keep the nice coaxiality, but of course the device will not have to come to sit, or we will avoid that it sits in that small lobe, yes? But so that's why we said also that we will more unsheath than push out. Just maybe while we push out 2-3 millimeter the device, we will 4-5 millimeters pull back on the delivery. That's how I would do it, like 1/3 push, 2/3 pull back, and then we can do it controlled and slow.
Okay.
Yeah, that's good. All right.
Okay, that's perfect. So what I'm gonna do now, I'm gonna keep my right hand with the knob still, and I'm gonna push more than pull.
Yeah, that's it. Yeah, that's what we expected. That's what I anticipated the device would do.
The image on the echo looks very good for us. We have less than a third of the device outside the ostium, so it looks very comfortable here.
So that was very well done. So what Felipe indeed did, so we kept indeed in the beginning the ball in the distal lobe. That's just to keep the nice coaxiality. But then because he pushed only a little bit, but he pulled more back on the delivery sheet. So then we know that the device would come out of there. And this is actually beforehand, before we were doing the case, on the echo we were discussing, this was where we anticipated the device to come to sit. Yeah, so actually really no shoulder, I would say, or and we have the compression on echo, but I like even to see more on the fluoro. You can maybe give 1 second of cine just for the audience. Cine is always easier to see, higher quality. Is this a cine? Or, yeah. Okay.
We're live.
Yeah. So based on this, I would say we have that 15 to maximally. Yeah, indeed. So this is indeed that 15 to 20% compression, I would say, visually.
Visually, I would say so.
Yeah, so it's more than 10%. It's not 30%, but it's there in the middle. But that's great. That's good. Yeah. That's
My
good.
impression here is that
We have some. Can you hear us?
Yep. Sorry, my impression here is that the device occupied the entire cavity of the LAA, and then the 35 that has been considered initially, in my opinion, it would be very large. So this is perfect.
I agree. I mean, I think at 35, we would be able to squeeze it in, but it would be, I'm pretty sure we would have a lot of shoulder. So, and personally, I do not like a lot of shoulder. I only accept shoulder if I know that there is a lot of tropicalization all the way up to the Commodore Ridge. Then you have to accept it, yes? But if that's not the case, I prefer not to have a protruding shoulder, yeah. Okay, so let's maybe, we can also do
We can make a small injection. Yeah. One of the important thing to consider just right after we were releasing the device is that different from the first generation, the way we deliver this new device, the Flex device, is way softer, it's way more controlled. And after we have it all fully open, I would say, so we keep a tiny little bit of pressure for 10 seconds, just to be sure that the anchors are gonna do what they have to.
Yeah, and we have to do a tuck too, yes?
Yes, we're gonna get there.
Okay, let it bleed a little out there, yeah. Okay, I think we fill first the sheet, let's do that before we do a cine. Yeah, we can close this one. Yeah, we do it. I do a tuck test normally, yes. But that's sometimes, especially if it's a patient with renal insufficiency, I would not give contrast right now yet. I would already do the tuck, etc., and only maybe give
a final injection.
But now,
Okay.
if I remember well, the patient did not have renal insufficiency.
No,
so we could
no
do,
CKD.
just for educational value, we could do an angio now, do the tuck, and repeat it. Yes,
Okay.
we could do that. All right. So let's do a cine. Yeah, let's do a cine. Felipe?
Okay, so you guys,
Yeah, that's nice.
It looks
I like
very good.
Yeah,
I like
the position. So, and it's almost immediately occlusive. Also, of course, it goes still a little bit of contrast through the device, but the fact that there's a very slow washout, that's indicative that it's occlusive. Yeah, and this is a very high likeliness that it's going to occlude completely, even on CT. It follow-up CT. So let's do a tuck maybe, Felipe, then you can open up here the hemostatic valve at the end. We can pull back a little bit on the...
Yes, can we have a microphone for Dr. Monica from the ECO? Just she's gonna talk about some of the best criteria. I'm just gonna pull a little bit here.
We have to bring back the delivery sheet first a little bit more.
Yes, I'm just bringing a little bit back. This is the maneuver very similar to the Minnesota one that we do with the ASDs and the PFO sometimes. So we give a little bit of space in between the delivery sheet and the device itself. So right after we have around 2 to 3 centimeters of spacing there. What I'm gonna do here is I'm gonna pull the knob. You can see my hands here. Okay, so what we are gonna do, this is the movement. I'm gonna be pulling the knob, okay? Okay, so the screen please, so we can have the echo image of the tuck test, also the angle. I mean the fluoro. Okay, so this is pretty much what we have. This is a fine tuck test. What we're looking for, we can see the distal marker of the device. The way that he comes back, he gotta go back to the last position. So we know the tuck test is okay.
Okay, I think this is looking excellent. I would say. So we can, I think it's good for educational values to give here that repeated, so people really see what the final position is. If you agree.
Yes.
And then, but maybe let's focus a little bit on echo still. Is there anything we have to still screen or on the echo? So what I personally look at it, we're sitting almost 100% to 90% distal of the circumflex artery, which is nice. We can cover all the trabecularizations. The device, it's nice coaxial with the central, with the LAA, which I also do like. We have enough compression both on echo. I don't know what they measured on the crown. What did they measure on the crown from size there? 25-ish, 24, 25. So that's exactly 20% compression.
Yeah. Okay.
That's also what I visually assess on 15 to 20% on the fluoro or the cine. So I think we're good to go actually. Yeah, we can indeed, let's do that. I'm quite confident based on what we saw on fluoro.
Fábio, Felipe, and Ole, we have still 1 minute. So if you want to summarize.
Okay, so let's release the valve.
So let's do
device.
we do a final angio and then we can do it. Yeah, all right. And then that's perfect. And then now we can go for the final. You have to probably open it still. And then, okay, let's go for the final release, and then we're done.
Angel, and I have fluoro here.
Fluoro, please.
I'm out of fluoro.
Yeah, now it works. Yeah.
Okay, so I'm just gonna rotate the knob anti-clockwise.
Let's keep the echo just on a normal view, please, on 45 degrees or so.
So that's it.
Yeah. Yeah, all right.
You can see the release.
So it didn't move at all. You saw it's rock solid on the fluoro, exactly the same position also on echo. So I think this is excellent. We can't do this better than this. It's completely occluded. I would say almost completely to the anatomical ostium even. So I think I have to congratulate Felipe and the team here. They did a great job.
So guys, I'm not sure we still have time. But I want to thank you all guys in the panel.
We should be closing, but on behalf of the panel and on behalf of all the attendees here at Copacabana Room in the Convention Center, we would like to congratulate Felipe, Ole, and Fábio for this very educative case from planning, which was very accurate planning, and we could see how it decreases the time of the procedure, which is very important. And you did what you planned to do. It was very, very educative. I would like to thank you and give you a great applause from here for all of you and for all the team in the CAT lab. Congratulations. Thank you very much for sharing this educative case with us.
Thank you, guys.